All right. Hey guys. It's Hash here. Again, sorry for not being there in person, but I thought I'll make it up by uploading a video on my presentation. I was asked to talk about epidemiology of acute coronary syndrome, but I'll talk about a few other things as well. And the next thing I was asked to talk about was heart failure treatment. I guess someone else is covering acute coronary syndrome management. Okay, so let's go on in epidemiology. It's a very common problem. In the USA, 1.3 million people comes in with ACS, and 1 million of them come in with non-STEMIs or unstable angina. In Australia, acute coronary syndrome cases is still high, 75,000 last in 2010, and chronic heart disease has the greatest morbidity um, of a single cause disease in Australia, and it's the cause of nearly 20% of all death in Australia, and one third of all death is related to cardiovascular disease. So that's chronic heart disease, peripheral artery disease, cerebrovascular disease. It's a big problem. Okay, and we all know about the risk factors from med school. The common non-modifiable causes include sex, male, specifically age above 65, and a family history, which is defined as a sibling or parents with a significant cardiovascular event at the age of less than 55 for 55 for females and 45 for males. That doubles the risk of you getting acute coronary syndrome. And other modifiable diseases, which I'll cover next on a study called the InterHeart study. Now, the InterHeart study was a pretty interesting study done in 2009. It enrolled 15,000 participants from 52 countries. It was a case control study, and it looked at modifiable risk factors that would in patients who came in for the first acute coronary syndrome presentation, and these are modifiable ones. Okay, so not non-modifiable ones. And the result from the study is pretty interesting, and results I'll show in odds ratio. Cholesterol being hypercholesterolemia being the highest risk factor with an odds ratio of 3.25. They used this very weird calculation for hypercholesterolemia, where they use the US calculation, but pretty much, I mean, I guess it's explained with simple hypercholesterolemia as well. Smoking is the next risk factor. Psychosocial stressors is quite high there, mainly depression and anxiety disorders. Diabetes and hypertension is there as well. We know about that, from before. And abdominal obesity, defined as abdominal girth larger than 36 inches. And three protective factors seem to be, moderate alcohol use, exercise, and having a lot of fruits and veggies in your diet. There's also something called the Framingham score as well, which basically calculates your risk of getting acute coronary syndrome in 10 years. And it covers, age, your blood pressure, and cholesterol level, and a few other factors as well. There's a few other controversial risk factors. We've heard about, highly sensitive CRP, but patients which can detect small levels of CRP. But unfortunately, in this day and age, especially the patients who come in, they're generally, in their 60s. Any inflammatory condition, any infective condition can also cause a raise in CRP, highly sensitive CRP as well. No one's recommended testing this at all. Homocystinemia is something that was looked about a few years ago, and folic acid reduces the levels of homocysteine, but no one's recommending, folic acid supplementation or homocysteine level checking homocysteine levels in patients. So these are controversial risk factors, but I'll just put it out there. Let's go briefly on acute coronary syndrome. ST, it can be divided into three. You have ST elevation the STEMI, which is defined as raised troponin or CKMB, and an elevation of the ST segment more than 2 millimeters in the precordial leads or 1 millimeter in the limb leads. And aside and if you don't have the ST elevation, it can be divided into either non-STEMI and unstable angina. The difference between the two being troponin or the raising biomarkers. Pathogenesis. Look, most of the time it's due to arthrothrombotic plaque obstruction, where there's atherosclerosis of the coronary vessels, and a rupture of the plaque leads to activation of the glycoprotein 1B receptor, which leads to platelet activation and further adhesions via the glycoprotein 2B3A receptor. And this leads to a formation of clot. So if you have a total occlusion of the blood vessel, a coronary vessel, that generally leads to a STEMI, or partial occlusion in unstable angina or non-STEMIs. There's this talk about white versus red thrombus, where red thrombus tends to be fibrin rich, tends to signify STEMIs, whereas white thrombus tends to have platelet rich thrombus. It's mostly found in patients with non-STEMIs after dissection of the retrieval of the clot. But I guess at the end of the day, it doesn't change the management. It's just more of a histopathological kind of thing. Interesting ECG changes. So we all know about after STEMI, the first thing that would change is actually the hyperacuity of the T wave, and it signifies the stress of the ventricular wall, which later leads to ST elevation within a few minutes or an hour. And that later on leads to a T wave inversion, which signifies ventricular wall death, and pathologic Q waves later on could develop as well. And the second picture I'd like to talk about is in regards to the pathophysiology of ST elevation or depression. In a STEMI, you have a transmural injury where the whole part of the wall is dead, and because of the negatively charged because of the negative charge of the dead cells, because of the charge of the dead cells, you have the movement vector of the electrical wave down towards the precordial leads, which leads to an ST elevation, whereas a non-STEMI generally is a subendocardial injury, and it moves the other way, so you have an ST depression instead. ECG territories, inferior leads 2-3 AVF, anteroceptor leads V1 to V4, and the lateral leads we know about. I guess the next thing I'd like to talk about is posterior MIs. You should look for if patients come in with an inferior MI, so an increase, so ST elevation in 2 of either 2, 3, and AVF. You look at the anterior septal leads as well. If there's depression in the V1 to V4, and tall peaked R waves in V1 to V2, you want to think about posterior MIs. So you do a V7 to V9 to rule it out. We've talked about diagnosis as well. I guess the next other thing I'd like to add about is if a patient comes in with a new onset or presumed new left bundle branch block, you tend to treat that as a STEMI as well. It's the diagnosis is based on ECG changes and biomarkers, raised biomarkers as well. CKMB rises and drops a lot quicker than troponin. Troponin seems to be a lot more sensitive and a lot more specific, and has good prognostic value as well. But I guess the main reason why you would use CKMB on top of troponin, if a patient has recurrent chest pains, you want to know whether that's a new STEMI or not. CKMB will be a lot quicker because it drops a lot quicker, and an increase in CKMB 2-3 days after your initial heart attack would suggest you probably have had ongoing myocardial ischemia. Differential diagnosis we should think about include tachycerebral cardiomyopathy, which is apical ballooning syndrome. Happens in mostly women due to a hyperadrenergic response from an emotional stressor. They would have raised troponins and ST changes as well, but on coronary angiography, nothing, and they tend to self-resolve by itself in about a few months' time. Pericarditis, aortic dissection type A specifically, where the intima tears into the coronary vessel itself and causes obstruction. This can also be another differential diagnosis as well, and PE and tachyarrhythmias can mimic this condition. Before I go on to heart failure treatment, I'd like to talk about TIMI score. It's mostly for the non-ST elevation acute coronary syndrome, so the unstable angina and the non-STEMI. It's a point system, the points listed there, and it's to stratify the risk of the patient, whether you should do an urgent angiography or PCI. Patients with low risk are classified as 0 to 2 points, intermediate risk 3 to 4, and high risk for 5 to 7. So patients coming with intermediate to high risk, you tend to do coronary angiography a lot quicker, just to rule out whether there's any stentable coronary vessels, and they seem to benefit a lot more than the low risk groups. Lastly, I'd like to talk about heart failure treatment. It's a bit of a sidestep from acute coronary syndrome. So before we go into pharmacological course, let's go into the non-pharmacological treatments. Exercise, we all know about. Salt restriction, less than 2 grams a day. And fluid restriction seems to be very patient dependable, but we tend to start with less than 1.5 liter per day. Reducing other risk factors such as obesity and smoking, and importance of pharmacoeducation, because most of the time patients don't comply with the medication, which leads to their exacerbations. These are the 5 main drugs used in heart failure. I'll cover a few others at the end. But I guess ACE inhibitors seems to be the mainstay, the main treatment that you start them on, and it works by inhibiting the angiotensin converting enzyme, which acts in the liver, in the lungs, and it prevents conversion of angiotensin 1 to angiotensin 2, and it blocks the renin, angiotensin, aldosterone sympathetic pathway, and also reduces afterload as well by causing vasodilation of the arteries. Most common drugs that we use: enalapril, perindopril, captopril, and it's indicated in all New York Heart Association classes. So it's very important in heart failure. Most common side effects seems to be hyperkalemia, and cough and angioedema seems to be due to the accumulation of bradykinins in the lungs or in the body. I guess the most important study you should think about is the SOLVED trial. I've gone through the RACP lectures, and the studies I highlight here are ones that are highlighted in the RACP lectures, and also in Up to Date as well. And the SOLVED trial seems to be a very important one, where enalapril was compared to placebo in patients with a ventricular ejection fraction of less than 35, and it showed a reduced mortality and heart failure symptoms in a 3-year follow-up. And X-SOLVE, which is a further extension of this SOLVE trial, showed a reduction in all-cause mortality. Now, this 30% number, I think I want you guys to memorize that, because it's a very important number in heart failure stuff, and I'll cover that in a bit. Next medication, beta blockers. So it basically reduces the neurohumoral activation, because there's chronic sympathetic activation in patients with heart failure due to a reduced ejection fraction. The body releases a lot more adrenaline and other adrenergic stuff, which and these actually cause ventricular remodeling. So giving beta blockers actually prevent ventricular remodeling as well, and some of them have vasodilating effects by alpha receptor blockade. And the 3 main drugs that you should think about are carvedilol. These are the trinity: carvedilol, metoprolol, and bisoprolol. There's a new one, nebivolol, which is useful for patients above 65, but I guess I won't cover that right now, but these three are the most important ones. And they're indicated in patients with New York Heart Class 2 and 3, and some studies suggest 4 as well. So you just start them on that. And the main common problem seems to be lethargy, which is what patients normally complain about, and the main reason why they come into hospital, bradycardia and hypertension. And rarely it can cause exacerbation of your asthma, but because they're very cardiac specific, the risk of that seems to be a lot more low. Carvedilol seems to be the most studied beta blocker. And the US carvedilol showed an all-cause mortality reduction by 35% in New York Heart Class 2 and 3. Well, the Copernicus study is a similar thing, but for a more advanced heart failure patients, New York Heart Class 3 and 4, showed the same thing as well, 35% reduction. So this number, 35%, 30 to 35%, is a very important number where all these drugs seems to be reducing all-cause mortality by 30-35%. Okay, Capricorn is another study in patients post-AMI with complicated LVF. So the cause of the heart failure is because of ischemic heart disease. Acute coronary syndrome. And carvedilol reduces all-cause mortality as well, but it's not as much. But it seems to be a study that people tend to brand around about. Merit HF searches looks into metoprolol control release. So this is not the standard metoprolol. This is the extended control ones, the longer acting ones. Again, 34% of reduction. Whereas the CBIS trial looks into bisoprolol with ACE inhibitors and diuretics. And again, 34% reduction in all-cause mortality. So ACE inhibitors, beta blockers, importante. Okay. Next one, aldosterone antagonist. They're more indicated for New York Heart Class 3 and 4, which is indicated by the RAIL study, showed a reduction in 30%, after 2 years on spironolactone. It works by antagonizing aldosterone, as the name suggests, which is a mineralocorticoid, and the heart has receptors, aldosterone receptors as well, and they found that patients with end-stage heart failure, actually the heart releases aldosterone as well. So it's a double whammy. It helps with reduction of aldosterone level in the body, and spironolactone is the one that we commonly use. Eplerenone is a newer drug, works the same. People say not as good, but less hyperkalemia and gynecomastia. But it's a lot more expensive. So people tend to start patients on spironolactone first. When they start having gynecomastia, the American College of Cardiology suggests conversion to eplerenone a month after starting spironolactone. Next, diuretics. Loop diuretics such as furosemide seems to be the main stay of treatment for patients with fluid overload. So it's only given patients who are symptomatic, patients with pulmonary congestion and peripheral edema, and it works by preventing reabsorption of sodium and water in the loop of Henle. Common side effects: hypokalemia, hyperuricemia, so it can exacerbate gout as well, hypomagnesemia, hypotension, and of course we know how it can screw up the kidneys as well. There's surprisingly not much data on diuretics in terms of heart failure, but meta-analysis suggests there's a reduction in mortality and definitely reduction in hospitalization and symptoms as well. And lastly, hydralazine and nitrates. These are combos which work by reducing preload, as nitrates causes venodilation, so of the venous circulation, and hydralazine causes vasodilation, so a reduction in afterload. But it's mostly indicated in patients, in African Americans at end-stage heart failure. And this was based on the VHEFT trial, which showed a reduction in all-cause mortality for all races, but there was a greater benefit for African Americans. And they think it's likely due to a higher risk of prevalence of coronary artery disease as the cause of their heart failure in these patients. And this seems to be beneficial for them. But most of the patients tend to stop using them because of hypertension and dizziness. And an important note is that hydralazine causes drug-induced lupus as well. Lastly, other medications we like to think about. Abravidine is a newer drug. It's a sinoatrial node regulator. So it's only for patients who are in sinus. And the SHIFT study suggested that there's a 20% reduction in cardiovascular mortality and hospitalization, but it's very expensive. It's not PBS approved, and you only see them in patients with end-stage heart failure who has tried all the other medications. Digoxin only in AF patients. There's no survival benefit, but there's symptomatic benefit as well. And lastly, calcium channel blockers. So the non-dihydropyridines such as the verapamil and the diazepam are generally contraindicated because they can actually cause heart failure themselves due to left ventricular decompensation. But the newer dihydropyridines such as amlodipine, felodipine might be useful in heart failure, but they're generally used in controlling hypertension. I didn't cover none in diastolic heart failure in patients who are coming with preserved systolic heart failure. There's no one's found any miracle drug to reduce that. Tends to be the general recommendation is to reduce blood pressure. So management seems to be the same as preventing the cause of the heart failure itself. So that's the brief overview on these two topics. Thank you, and hope you guys have a great time. I'll see you guys next week. All right, take care.